Now, speaking about the diagnostic management for the toxic goiter. Number one, clinical assessment. Is it toxic goiter or not? Sometimes there is intermediate cases or doubtful cases we cannot diagnose provisionally as a toxic goiter. So there is what we call clinical scoring. It is called the YAN score for the clinical provisional diagnosis of toxic goiter. Number two, laboratory diagnosis. There is non-specific investigations, for example, the serum cholesterol, the blood picture, the liver functions. For example, for follow-up of the antithyroid treatment, it may increase the liver enzymes, for example, but the specific laboratory investigation is what we call the thyroid profile. Thyroid profile means assessment of free thyroid hormones, T3 and T4, and assessment of the TSH, and we will see how to proceed with the thyroid profile. Then we can assess the autoantibodies for the autoimmunity, for example, anti-TSH receptor antibody, the antimicrosomal antibody, which is positive in nearly 95% of cases of Hashimoto thyroiditis. It is called antimicrosomal antibody. And there is antithyroglobulin and anticolloid, which may be positive in nearly 60% of cases of Hashimoto thyroiditis. All are autoantibodies for the thyroid gland. And assessment of calcium and parathormone, assessment for malignancy by the thyroglobulin, which is increased in differentiated thyroid cancer, assessment of calcitonin, which is raised, which can be elevated in medullary thyroid cancer, and also assessment of red oncogene expression in some cases of hereditary or familial medullary thyroid cancer. Then, after doing laboratory investigations and mainly the thyroid profile and assessment of the thyroid hormones, we shift into an important radiologic investigations, and the most important one is the thyroid ultrasound. What are the data we can get from the thyroid ultrasound? There is multiple data. Number one, about size. Is it normal thyroid gland or enlarged thyroid gland? Is it normal or enlarged? Is it symmetric enlargement or nodular enlargement? Is it symmetric or smooth enlargement or nodular enlargement? Is it solid or cystic? What about the invasion of the adjacent structures in cases of malignancy? What about the vascularity? And the vascular lesions are usually maybe inflammatory, maybe neoplastic, and maybe toxic lesions. Or it may be cyst with increased vascularity, it is suspicious cyst, for example. About assessment of the lymph node, about taking biopsy under ultrasound guidance, there is multiple benefits of the thyroid ultrasound. Then what about the thyroid scan? Number one, what are the materials used in doing thyroid scan? We use radioactive iodine, and types of radioactive iodine may be iodine 123 and 131. The 23 is diagnostic and the 31 is therapeutic. How? 23 usually emits gamma irradiation, which is harmless for the gland, so it is mainly used for diagnosis, and the half-life is shorter than 31. Half-life is shorter, so it is mainly used for diagnosis. But the 31 emits beta irradiation, which is destructive for the follicles, and its stay for the half-life is nearly several days, so it is mainly used for ablation in cases of toxic goiter, mainly Graves' disease, or ablation in a case of cancer of the thyroid gland. This is about the radioactive iodine. But recently we use the technetium scan because it is harmless, it is very short half-life, nearly 6 hours, and it is very safe, and it is more practical than iodine. So iodine nowadays is reserved for ablative means only, and the diagnosis depends on the technetium 99 berticnitate thyroid scan. What are the indications of thyroid scan? What are the indications? Number 1, diagnostic. Number 2, therapeutic. The diagnostic indications of the thyroid scan used, number 1, for anatomical delineation in cases of ectopic thyroid, or to know where is the source of toxicity. For example, it is toxic nodule or what else. This is anatomical indications. Number 2, for studying the function in cases in doubt. If I am in doubt, I calculate the thyroid uptake, and usually 24-hour uptake nearly between 10% or 25%. If it is more, there is increased uptake that denotes toxicity. So it measures the uptake, it is functional. Or may assess the pathology. For example, in a case of solitary thyroid nodule, what about the cause of this nodule? So it is one of the most important investigations for the solitary thyroid nodule. It is solitary thyroid nodule is the thyroid scan. And about the therapeutic uses of the thyroid scan, of course, it is for ablation in cases of Graves' disease when it is indicated. Number 2, ablation for malignancy. Malignancy if there is residual or nodal metastasis or distant metastasis. It is ablative, mainly iodine 131. It is the ablative use of thyroid scan. Interpretation in cases of solitary thyroid nodule, the scan as we see in this photo may show, number 1, warm nodule. Warm nodule means that the uptake of the nodule is exactly like the remaining part of the thyroid. Or maybe cold nodule, the nodule does not take at all any dye and the thyroid gland take the dye as we see in this photo. And it may be hot nodule, the thyroid takes the whole dye and deprives the gland from taking any dye. It is hot nodule. لما نقول واحد كده ايه اناني خد كل حاجه وحرم بقيه الاسره انها تاخد اي حاجه. Of course it is mainly toxic nodule because it takes the dye and deprives the gland from taking. What about the differential diagnosis of warm nodule? Usually it is multinodular goiter, but maybe adenoma, and the incidence of cancer is 10%. Then the cold nodule, it is mainly cyst or sometimes calcification, and here the cancer incidence rises into 15%. And about the hot nodule, usually it is toxic nodule or autonomously toxic nodule. Sometimes it is some sort of focal thyroiditis. It is active also, and the incidence of malignancy is 5%. So there is always incidence of malignancy in all solitary thyroid nodule. Take care, do the scan, and you must take biopsy from this nodule by fine needle aspiration to exclude the possibility of malignancy. In this photo, we can see different forms of the thyroid scan. In the first one, which is number A, this is normal. Number B, the primary toxic goiter, and observe the diffuse increase of the uptake. In C, we can see an example for secondary toxic goiter or plumber with heterogeneous intake by the nodules. There is multiple hyperactive nodules or hyperactivity in between the nodules in the internodular tissue. And in number D, an example for the toxic nodule, and in number C, the example of thyroiditis with heterogeneous uptake of the dye. Again, another photo. In number A, this is the normal. In number B, this is the Graves' disease. In number C, this is the plumber disease with multiple hyperactive nodules. And in number D, an example of a toxic nodule. Then shift to another tool of investigation, which is endoscopic investigation. And there is no case of thyroid disease without examination of both vocal cords by indirect laryngoscope to assess the states of both vocal cords for the possibility of next surgery. Then we shift to what we call fine needle aspiration. and it is essential investigation to exclude malignancy, fine needle aspiration, and these are the results of fine needle aspiration. It may be benign and we can follow up for this. It may be malignant and we will proceed for further surgery and further management. It may be insufficient, needs repetition, or may be suspicious. I cannot differentiate between, for example, follicular adenoma or follicular carcinoma. Both are differentiated cells. So I must proceed for higher biopsy, either core biopsy to see the direct invasion, or even for hemithyroidectomy to know the exact stigmata of malignancy. So if it is suspicious, proceed for higher biopsy.